got an alternative pointer. Thank you, Kurt. All right, so many of you know that there's been a renewed emphasis within St. Luke's health system for keeping patients with acute ischemic stroke head of bed flat during their first 24 hours. And I was tasked with telling you what went down with head of bed flat. Okay, and I'm going to start at the very beginning, and I mean the very beginning. And here we go. All right, our story starts in the 1950s. This right here is Dr. C. Miller Fisher. Did you and Andre know Dr. Fisher? Okay. So Dr. Fisher, he was a Canadian neurologist, known as the father of stroke neurology. He published hundreds of papers on stroke and other topics, and he was specifically during his time in Boston. So he had written, this was in Harrison's Principles of Internal Medicine, which is still a famous book today. This is when Harrison was still editing that book in 1958. And he wrote, "In the upright posture, the cerebral circulation falls, and for this reason, it is recommended that patients with a stroke as a result of ischemic infarction should remain horizontal in bed for 7 to 10 days initially." 1958. All right, moving onward to the 1960s, when we still had separate male and female wards with small privacy curtains, which I'm sure we're all wish we still had, right? All right. This was a paper published by Dr. Toole, the effects of change of head, limb, and body position on cephalic circulation. Dr. Toole had noted in a number of stroke patients, just lifting the head of the bed up caused a dramatic worsening in their neurologic function. He was famous in his abstract when he wrote, "Don't move, you'll perturb your homeostasis. Changing from the recumbent to the erect position results in profound readjustments in cerebral circulatory dynamics." And he was correct. Going forward to the 1970s, we got Richard Simmons. He published his Never Say Diet book, which I'm sure you've all read. But more importantly, we got the term positional cerebral ischemia. This is Drs. Kaplan and Sergey that published on 4 specific patients who they described had recurrent, dramatic, transient clinical worsening accompanied by elevation from the supine towards the sitting position. So this is where that term positional cerebral ischemia first developed, 1976, Kaplan and Sergey. I think it's very interesting reading just a couple of brief excerpts from their discussion points. It's so fascinating for me as a stroke neurologist today to see that they were dealing with the same disease and the same difficulties we deal with today, and reading about how they dealt with it. So they describe each of the subjects of this report had arteriographically documented occlusive cerebrovascular disease. So they did angiograms on each of these patients. Occlusion of the basilar artery had developed in 2 patients. One patient had occlusion of the carotid bifurcation, and another patient had severe stenosis of the anterior cerebral artery with infarction. We have not seen posterior cerebral ischemia in patients with disease of small penetrating blood vessels. It has always occurred with major vessel occlusive disease. They say transient ischemic attacks, which prior to MRIs, we now know this is likely progressive infarction that was occurring, and a fluctuating clinical course were features of each case. Striking dramatic central nervous system deficits occurred while the patients were erect. In the patients with posterior circulation disease, these consisted of respiratory arrest, stupor, and bilateral brainstem signs, just with changing their positions. This is one of their such patients. Here's the angiogram in their published report. This is an angiogram. There's the left vertebral artery, right vertebral artery, and what you can only see the proximal segment of the basilar artery. All the rest, there's no flow within it. So you can imagine this patient that has no blood flow throughout their brainstem. As soon as they put the head of the bed up and they had less blood flow via their collaterals going to this location, they had dramatic worsening in their condition. And we still see this today if we have patients where the clot cannot be retrieved. Going on, let me back up. In the 2 patients with occlusion in the carotid circulation, altered speech and hemiplegia developed. Dramatic improvement was noted when the patients were placed supine or in the Trendelenburg position, so not just going flat, upside down a bit. Postural hypotension was absent in 3 patients and minimal in 1. All patients were maintained essentially supine for 3 weeks. So any ICU nurse that gives me a hard time that I want a patient flat for a day or 2, 3 weeks, 3 weeks. After which they were slowly and carefully mobilized. 1 patient developed cerebral infarction, the other 3 patients escaped without significant neurologic deficits. I'm not sure what they term significant, they survived. I'm sure MRI would have shown all of these patients had cerebral infarction. This is one of their angiograms within the carotid circulation. This is the common carotid. This is the internal carotid artery, which is occluded right here at its origin. This goes up into the external carotid artery. And then this person had retrograde flow from the external carotid artery through the eye, through the ophthalmic artery, and then into the middle cerebral artery. This is one of the common retrograde pathways if you have an ICA occlusion that the body naturally tries to shunt blood flow through if you have an occlusion of the ICA. All right, so they concluded, our experience here in reported has led us to conclude that in some patients with occlusive cerebral vascular disease, position in bed may be critical. Positional worsening should be sought for, especially in patients with fluctuating signs. These patients should be maintained either supine or in the Trendelenburg position, and after an undefined period, best determined by trial and error, the patient should be gradually mobilized with caution and supervision. We're often asked, so when is it safe to move the head of the bed up? And we have this arbitrary 24 hours right now, but in reality, some patients it may be sooner, some patients may be later. It depends. Has all the clot been retrieved? Has some of it been retrieved? How young are they? How good is their collateral circulation? Everybody's going to be a little bit different, and it's very difficult to give a prescribed, this is the exact amount of time that this patient, really it is when you have these patients and you, for the first time, especially after they've been head of bed flat, you want to carefully note in the following minutes and hours if you notice, hey, they're a lot worse just since I decided to bring their head of the bed up to maybe get something to eat, be evaluated by one of the therapy teams. If you notice this is something that we want to know about, and we want to immediately put the patient back flat. Sometimes we'll do fluids and other augmentations. All right. Moving on to the 2000s, we have Schwartz and colleagues published the effects of body position on intracranial pressure in cerebral perfusion patients with large hemispheric strokes. They looked at 18 patients with complete or subtotal middle cerebral artery strokes. They looked at the mean arterial pressure, cerebral perfusion pressure, the intracranial pressure, and then they also looked at the mean flow velocities with transcranial Doppler ultrasound in different head positions. So this is just a diagram of the incidation with a transcranial Doppler. We use this technology, as Dr. Alexandrov said, here at St. Luke's, part to his mentorship here in helping us get the right machines and right things in place. So this is incidation through the temporal window right here, and you can actually incidate all of these intracranial vessels. Right here is the middle cerebral artery, and that's the one that they were specifically looking at. So these 18 patients, they all had blockages of this, or strokes, I should say, within this middle cerebral artery distribution, whether the left or the right side. And so what they did is they then looked at that mean arterial pressure, the cerebral perfusion pressure, and the ICPs, and then more specifically, they looked at the mean flow velocities. And they looked at the ipsilateral side, so the side of the stroke, and then they looked at the opposite side, and then they looked at the different positions, so 0 degrees, 15 degrees, 30 degrees, and then back to 0 degrees. So one thing you notice is as the map decreases, so the map decreases as the head position went up, and then you'll notice on the contralateral side versus the ipsilateral side. So just starting out, the mean flow velocities were higher on the affected side, but what you mainly notice is that the dip, right? So this dip going downward as you change position is much more significant. And they concluded that there was a loss of cerebral autoregulation on that affected side, and changing position had a much greater effect on reducing blood flow on that symptomatic side compared to the contralateral unaffected side. This is one of their patients that they showed that, again, dropped in mean arterial pressure, and they showed the left was the stroke side, the symptomatic side, the right was the unaffected side, And you can see that with changing head position on the unaffected side, pretty much no change in the mean flow velocity. But on the side of the stroke, there was a dramatic drop and then improvement with head of bed positionings. So we've known for some time that truly changing position can cause a dramatic difference in blood flow. Now, this study, published by our own Dr. Ann and Andre Alexandrov, heads down, flat positioning improves blood flow velocity in acute ischemic stroke. So this was published in 2005. They looked at 20 patients with acute stroke in less than 24 hours. Their median NIH stroke scale was 14. They all had a persistent arterial occlusion within the anterior circulation. They looked at the MCA mean flow velocities. They showed that they increased in all patients with lowering the head of the bed. So you lower the head of the bed, and then they showed that there was an average of 20% improved blood flow. But this ranged between, depending on the patient, between 5 and 96% improved blood flow from baseline with just putting the head of the bed from 30 degrees down to 0 degrees. In 3 of the patients, they noted that there was an immediate neurologic improvement. This was their study, again, showing their baseline flow on all their patients, their average, and then going to 15 degrees, you've got a 12% flow increase, then to 0 degrees, you got an additional 8%, so total yield 20% increased blood flow without any medications, with no augmentation, just putting the head of bed flat. You're immediately giving a patient that has a stroke, that may have a blockage, 20% more blood flow. It's amazing, right? And it's free. St. Luke's must love that, right? It is free. It is free, no cost. Just put the head of bed flat, and you're going to have an improved blood flow for these patients. This is one of their patients that they described. So here are patients at 30 and 15 and 0 degrees. These are the waveform. This is the output that we get with a transcranial Doppler. So these are the middle cerebral arteries. So these are the waves. And then these are the flow velocities. You can see 30, 39, and 45. So you can see that gradually as that head of bed goes down, you can see a more robust waveform. You can also see that that mean flow velocity is increasing as you put that head of bed flat. Then came the famous, or I should say infamous, HOB trial. This trial came out in 2017. I was at the International Stroke Conference as it was presented, and it was, well, let me go into it. So after 60 years of data showing that with patients, specifically with these large vessel occlusions, there's likely a very significant benefit with keeping the head bed flat, the HOB trial was finished, and let me talk about it a bit. So the HOB trial. So their aim was trying to answer this question in a very large randomized trial of looking whether patients lying flat or head of bed at 30 degrees was there actual change in outcome. They wanted to use a broad range of hospitalized stroke patients. So the trial ran in 114 centers, none in North America, very few representation in Europe. But they did have a very strong number, 11,000 patients that they recruited in these sites. But many of these sites, I personally have lived in South America for a couple of years. Many of these sites, there's not ambulances. People are very late to seek medical attention. And when they do seek it, they're usually walking in many days later. And that's just how it goes in different countries, that there's limited health care and also limited resources. So, but nonetheless, they had a high number of patients. Here's their baseline characteristics. They were pretty similar. The thing to note is that their median NIH stroke scale, so again, that's a 42-point scale for those of you aware, was 4. So very minimal deficits of as far as their median scores. Also, the time from onset that they started their trial median was 14 hours, but then they had an additional 7 hours that they could randomize the individuals. So up to 20 plus hours by the time people would be randomized to whether head of bed flat or sitting up. Here's the different types of patients. One thing you'll notice in their breakdown, they included patients with hemorrhages, which completely different pathophysiology of a patient with a hemorrhage compared to an acute ischemic stroke, especially a large vessel occlusion. But nonetheless, they were all lumped together in this study. And with regards to the different patient populations, they had over 10% of the population, the intervention was discontinued. So some of that was the patient couldn't tolerate it. The doctors were actually allowed, if they had a preference of the patient being flat or head of bed up, they could actually go against the randomization. So there was a lot of problems with the study, and not surprising, they didn't show any significant effect for head of bed up or lying flat in this population of both ischemic stroke and intracerebral hemorrhage. They looked at their different subgroups, also no significant effect favored one group or the other. So their findings were that there was no differences in effects on disability outcome. Positioning is safe. I think the only thing that was helpful from the study showed that there was no serious adverse effects from keeping a patient head bed flat. There wasn't any increase in aspiration pneumonia, which is always the fear. Well, how much more aspiration are they going to get if we put them head bed flat? At least in this very large study, there was no increase in pneumonia from doing so. So again, no clear benefit or harm in all their subgroups. So we go back to the famous Dr. Fisher. Was he right? Was he wrong? He wasn't alive to defend himself, so we needed somebody to defend him. That's right, Dr. Anne Alexandrov. She posted a rebuttal, her and colleagues, with Andre, her husband, head post, rightly positioned or flat out wrong. Okay, so in this, she talked about the weaknesses of the head post trial, the low NIH stroke scale. So the patients that you're gonna see the greatest effect on this, of course, is with a large vessel occlusion. Given that median NIH stroke scale of 4, very few people were in that category. The late presentation, so you're missing the most important time period when this intervention would be effective. The fact that you had both ischemic and hemorrhagic strokes. Over 10% of people the intervention was discontinued, and then their open design of study could potentially added some bias and confounding. So, Dr. Alexander said, I will design a better study. And so she did. So published in this year in JAMA Neurology, optimal head of bed positioning before thrombectomy and large vessel occlusion, stroke, a randomized clinical trial, also known as the Zodiac trial. So it was an NIH-funded prospective randomized outcome blinded evaluation clinical trial. They conducted it at 12 centers, 5 academic, 7 community centers. Their primary inclusion criteria was the evidence of a large vessel occlusion on CTA, and they had planned treatment with thrombectomy. They looked at 92 patients. They had planned on 182, but the trial was halted early due to strong efficacy. But 92 patients were randomized to head of bed at 0 degrees or head of bed at 30 degrees. They did repeated NIH stroke scoring every 10 minutes from the time of randomization until they moved to the catheterization table for thrombectomy. So here's her patients. They screened 258, 92 patients were randomized, 45 to the head position 0, 47 to 30 degrees. 15, interestingly, in the 0 degree group, 15 at the direction of the interventionalist did not receive thrombectomy, and 8 did not receive thrombectomy. This is dying, Kirk, in the other arm. And their baseline characteristics were pretty matched, so matched in age and gender. The arrival, most people came by ambulance. It's always interesting to me, people with these large vessel occlusions, there's always a small percent that come by private automobile, which of course, their head of the bed they're up, sitting in their seat, I should say, which is of course gonna be worsening them the entire transport time there. This was the head position when they were first encountered by the stroke team. You can see most patients brought in by EMS because the cardiac monitors are head of bed up. They had pretty similar NIH stroke scales between the two, so they were well matched. The aspect score, that's a score that we use on CT scans. It shows signs of early ischemia, and they, based on that first CT scan, and they were well matched there. And their pre-stroke baseline, as far as their disability with the modified Rankin, was also similar between the two groups. Most people had a middle cerebral artery occlusion. They were very well matched in the number of patients that got alteplase or tenecteplase. What was not well matched was that the the patients that had head at 0 degrees presented at much later time windows. So this is in minutes, so it's 161 versus 71 minutes, and therefore their stroke onset to thrombectomy averaged 4.47 hours compared to 2.67 hours. So if anything, the patients with head at 0 degrees had a much longer delay until thrombectomy, until that clot was removed. So you would expect, given that longer delay, they would have worse outcomes. But that was not what was seen. What they showed, people that had a greater than 2-point decline, there was only one patient in the 0 degree group versus 26 patients in the 30 degree group. With patients that had a greater than 4-point decline, there was 1 patient in the 0 degree group and 20 patients in the 30 degree group. So graphing this out, if patients with these large vessel occlusions come into our emergency room and are not kept with head of bed down, over 40% of them are going to have a greater than 4-point worsening, and then over 50% will have at least a 2-point worsening just by not keeping the head of bed flat when these patients first come in to the emergency room. What was astounding was that these results, even post-thrombectomy, persisted. Patients that were kept head of bed flat, as far as what percent of patients had improvement at 24 hours, 86% of patients with head of bed flat versus 59%. And even looking 3 months out with the modified Rankin scale, more patients, there was a greater number of patients less disabled, and we'll look at this. So here's the modified Rankin scale. For those of you unaware, modified Rankin 0 is no disability, up to 6 is death, so varying degrees of disability. 2 is functional independence. They have deficits, but they can still be functionally independent. 3, they can walk, but they're disabled and are not functionally independent. 4 and 5 are varying degrees of inability to walk and severe disability, and depending on their level of nursing care. So you can see there's a shift, even at 3 months, just from this simple, free intervention. There's a shift towards better outcomes, even at 3 months in these stroke patients, just by being kept head of bed flat. I love that they pointed out the number needed to harm. So for a 2 or more point worsening in the NH stroke scale, the number needed to harm was 1.88, meaning just about for every single patient that's not kept head of bed flat when they come into the emergency room with these large vessel occlusions is going to be harmed. Dr. Alexandra's conclusions were that 0 degree head positioning is safe and imparts stability and clinical improvement in LVO patients during the pre-thrombectomy period, making it an important rescue procedure. Use of 0 degree positioning may be one of the most important first steps in managing a LVO thrombectomy candidate. This is critically important when immediate access to thrombectomy is unavailable, especially in those LVO patients requiring hospital-to-hospital thrombectomy, which of course in Idaho, this occurs a lot in our 9 sites, right? We have patients that are being helicoptered from all across the state to our center. So even more important, if they've already presented to an emergency department, they already know that it's not a hemorrhage, it's a large vessel occlusion, they're coming for thrombectomy, they need to be head of bed flat. So future research questions to conclude. Do patients with, other questions that we still do not know the full answers of, do patients with large vessel occlusion benefit from 0 degrees head positioning post-thrombectomy? Do middle vessel artery and distal vessel artery and lacunar ischemic stroke patients derive benefit from 0 degree head positioning? What length of time is ideal? 3 weeks? I know the ICU nurses look at me, no, please, not 3 weeks, right? We can't keep them in our ICU 3 weeks. We need a better way to measure. This is my own personal opinion. The best measurement that we have in outcomes that is broadly utilized as the NIH stroke scale, it's a 42-point scale that we're using to say what is somebody's deficits, when we're talking about 86 billion neurons in the human brain. And trying to look at effect size in a 42-point scale that's supposed to represent 86 billion neurons, I believe is fully inadequate. And I hope for a future day that we'll see many more interventions that show benefit because we have better ways of measuring this degree of injury. So our best practice currently at St. Luke's is that EMS, thrombectomy transfer, and ER teams are instructed to keep all ischemic stroke patients with head of bed flat. in all admitted ischemic stroke patients are placed with head of bed flat 24 hours until cleared by neurology. And that's it. Thanks, everybody. Before I formally conclude, I know you're going to hear by Dr. Ann Alexandra, but I'd like her to stand up, and I'd like a round of applause. It was this woman's sheer determination and that of her husband that made 60 years of prior data relevant today. And this is one of the greatest effect sizes in stroke care, and one of the greatest effect sizes in medicine, to have a number needed to treat of 1.28. So I'd like to commend Doctors Alexandra for their tremendous work. Thank you so much.